anatomy and physiology. It is not pathophysiology. You do not need to know it for the final, other than that you should know it to even be in this class. But it is not on the final. I suppose aspects of this are on the final. Just be familiar with this and what the words mean. This is on the final. I should say, knowing that the motor pathway, corticospinal pathway are the same thing. And because the table that's coming up is on the final, so you should have an understanding of upper and lower motor neurons. Okay, this is definitely on the final. Okay, we've drawn the brain trees several times. This is on the final. Okay, from tendon reflexes up is on the final. Okay, from here up, you should have cards made for everything from tendon reflexes up. If you haven't seen it yet, I did post a Kahoot to the neuro module with practice questions on it, and one of them is very similar to a practice question that will be on the exam, or to a regular question that will be on the exam. Okay. This is on the final. So I will ask you about bilateral weakness and name one of these four things. And you need to tell me where that takes place. Okay? These are important paths to be aware of, right? So if I ask you about an issue with vibration and proprioception, you need to know that that takes place in the posterior columns. And if I ask you about pain or temperature, you need to know that that is the spinothalamic tract, right? This is pretty much the exact same thing we were just talking about. Know what they are. You don't need to know what any of them are. It's helpful to know, like you could get quizzed. T10 is the umbilicus or umbilicus, whatever you want to call it. You should know this. It is on the exam. This is not on the exam. This is on the exam. Okay? So basically, if I ask you about a stroke in one of these areas listed here, what deficit are we expecting? Or, conversely, if I ask you about the deficit, what area is it taking place in? Okay? This is just kind of a continuation of the last slide. Okay, nerves. I narrowed it down to 6 nerves in the study session the other day. You do not need to know nerve 2, 3, 4, 6, 11, or 12. Okay? You do not need to study 2, 3, 4, 6, 11, or 12. The rest of them are fair game for the exam. Okay? 2, 3, 4, 6, 11, 12. Hopefully that gives you a head start on at least the cranial nerves.
2, 4, 6, 11, 12?
2, 3, 4, 6, 11, 12. Basically nothing to do with the eyes. Okay? Make sense? Everyone? You were there, you already knew that. Yes?
Do we know like nerve 5 is whatever name? Or like...
You know, I got asked that before, and I don't think so. I don't want to pull it up on my computer right now, just in case.
So I just want to know like the name of the nerve and what it does.
I think I know. I think I wrote it on the exam as the name of the nerve. Okay. But I can go through and try to make sure that I also include the number with it. You guys didn't have to memorize that for health assessment? Like 1 olfactory, 2 optic.
My health assessment professor actually gave us, like, let us bring in a full piece of paper for all of our tests. We got a full 9 by 11.5 paper. So you would get writing that's literally like 7-point font on there. The only rule was it had to be handwritten.
I literally had to memorize a 30-minute script. Like I was putting on a Broadway play. Okay? Woo. All right, well, whatever. Anyway, that is your first neuro set of slides, okay? Set number 2. How are you still scanning? Come on. How do I have 5 new emails? Okay, why don't you come back over to my computer? Okay. Anyone else's internet not working?
Today.
It's not very fun for me. While we're waiting for the internet to start working on my computer again, if you went to Slice and Advice or met with a research librarian, I have a little paper you can put your name on. I was at Slice and Advice for 3 hours, so I know if you were there or not. But it's helpful if you write your name down. If you met with a research librarian, please show me on your phone or computer your confirmation of your appointment or something of the sort. And come write your name on my paper. Also, I've decided that the epidemiology section of your poster is going to be extra credit. Because people are stressed. Technically, you guys are section 1, and I accidentally put section 2 there, so you just put yours there, and we'll scratch the numbers out instead. Hello?
My appointment with the librarian is today.
That's fine. You send me an email after your appointment.
Okay.
I will give you the points. Thank you. Oh, yeah, sorry. I didn't mean to steal the pen away. All right. Are you done sliding yet? The epidemiology section will be extra. I feel like it's stressing people out. The poster. All right, where did we leave off? Stroke? Okay, well, I'm going to quickly go through the slides before stroke so you can see what will be on the final and what will not. And then I will talk to you. Any of you have proof to show me, or were you all at Slice and Advice?
I got it.
All right. Sounds good. Yay, we love extra credit. Yeah, I heard people are stressed about this epidemiology section. I don't know. I'm making it worth 2 points of extra credit. Slice and Advice was worth 5 points. You guys are just really racking up the extra credit right now. What? Yeah, and the more you panic, the more stressed I get. So it, works out kind of. It's not very good, probably. I'm deciding what the extra credit will be on the exam. Yes? Yeah, if you have not already done an epidemiology section, just eliminate it. If you already did it, you're going to get extra credit. If you didn't do it, don't stress about it. How about that? Yay! Beautiful. I love it. I saw you. Okay, you're good. Okay. Now, let's move on to Dr. Aparwa's slides. So I realized after over the summer, in my mind, I was like, these are such great slides, I love them. And now, this quarter, I'm like, wow, I don't like these slides at all. So, I eliminated many. And also, some of them I left in because I'm like, well, these are good things for them to know, but I'll let you know whether or not it's actually on the exam. Or something you should study for the exam because it's like a wrong answer on the exam. Okay? Alright. Lou Gehrig's disease. Important to know. Is it on the exam? I think it might be on the exam. 1 question? 2 questions? I don't remember. But you should know. Okay? Again, Lou Gehrig's disease. Okay, notice what is not there. Any of the statistical data related to Lou Gehrig's disease. You don't need to know that it's the most common motor neuron disease in the United States. Okay? If the slide disappeared, don't study it. Okay? Abnormal posturing, it is definitely on the exam. Okay? And the Kahoot has a question on there. And I wouldn't put the same question on the Kahoot as I put on the exam, so hint, hint. 3 points. Well, for people who are paying attention at least. All right. Symptoms of brain injury. So, important, not on the exam.
Important, not on the exam.
Important, not on the exam, which means to you it's probably unimportant, which is fine. But here it is if you ever need it. Okay. All right. Spinal cord injuries, important, not on the exam. Okay? Same with this one. Important, not on the exam. Okay? I care that you know that a spinal cord injury could cause these things over here. Where's my mouse? There it is. I care that you know that. But there are a lot of other things on this exam. It's just kind of some really meaty slides. So I'm just going to let you know, don't waste your time studying this, okay? But you have it if you need it. You can be like, let me look at my slides that we got posted in class because I know it's there, okay? All right. Neuroplasticity, not on the exam. Important to know, not on the exam. I don't even know what I would test you for on this slide, but what is neuroplasticity, I suppose. But there are more important questions than that to ask. Brain bleeds. Important slide. This is on the exam. Okay? Important slide on the exam. Yes?
Do we need to know the specific location of it, or just like if it's arterial?
No, well, so if I tell you that your patient has a bleed between the dura and the arachnoid space, you need to know whether it's most likely a venous bleed or an arterial bleed. Symptoms, probably worth knowing. The Glasgow Coma Scale, we did not go over it. We will not go over it. There's not time for that in this class, but you will go over it in your med-surg class. Anyone in the ICU has this done at least twice a day, sometimes more.
You said Glasgow, we won't need to know on the exam?
You do not need to know the Glasgow Coma Scale for the exam. It is an assessment used in brain bleeds or any sort of loss of consciousness, but you don't need to know it for my class. All right. We got here. Did we start this?
Yeah.
We did. Okay. You do not need to know the most frequent cause, top 5 causes, 1/3 die, 1/3 significant deficit. You do need to know the signs of a stroke. Okay? The other thing you need to know, if I have a stroke, is my forehead paralyzed? No, it's not. As long as my stroke is hemispheric, right? As long as it takes place on only one side of my brain, then my forehead is not paralyzed. Whew. In Bell's palsy, is my forehead paralyzed?
Yes.
Yes, on the side of the lesion. Which nerve is Bell's palsy associated with? 7. What's the name of nerve 7? The facial nerve. Good job. All right. Risk factors for stroke. You should know these. Did we get to this? Yes? No? Maybe?
We didn't. No.
Let's just talk about this one then, since we're here. Okay. Risk factors for stroke include hypertension, which we have learned about multiple times, atrial fibrillation, which we have learned about, African American heritage, smoking, high cholesterol, a sedentary lifestyle, and a prior stroke or transient ischemic attack. A transient ischemic attack is like a mini stroke, okay? It's important to note that those with an asterisk here are modifiable. So hypertension, we can control hypertension. At least we can try. Atrial fibrillation, again, medications can help control atrial fibrillation. There are treatments to help control atrial fibrillation. We cannot control our ethnicity or heritage, right? Smoking, we can stop that. High cholesterol, again, medications, diet, lifestyle changes. sedentary lifestyle, we could become less sedentary. You cannot change whether or not you've already had a stroke or a TIA. So a lot of things related to stroke as risk factors are modifiable. And then you don't need to know medications. It is important to know the types of strokes though, right? We've gone over that. Hemorrhagic strokes, ischemic strokes. You don't need to know the like 20% are hemorrhagic, 80% are ischemic, 1/3 die at the time. Like I took that slide out. You don't need to know all of that. But hemorrhagic stroke meaning a bleed, right, in the brain, and ischemic meaning a cutoff of blood flow and a lack of oxygen. Okay. These medications that they're talking about in this slide, so platelet inhibitors or anticoagulants, those would be for ischemic strokes, right, because they'd be preventing blood clots. All right, seizures. This is important to know. It is not on the exam. Okay? So seizures are basically like hyperactivity in the brain. The neurons are firing at an especially high rate, uncontrollably and in an unorganized way. So it's considered sudden, explosive, disorderly discharge of brain neurons, which you can kind of see in this EEG here. Have you guys ever seen someone get an EEG? They like put all these electrodes all over their head. I had to do like a makeup clinical day. I got bronchitis when I was in nursing school, and normally I was on like a heart transplant floor, so I couldn't go to clinical that day because I couldn't get the people who just had a heart transplant sick because they're immunocompromised. So then I had to do my makeup day at the end of the semester, and I was on like a neuro floor, and these are all people, like all the people I had as patients that day were on seizure precautions, and they all had video cameras in their room, which they consented to. It wasn't like, surprise, you're actually on camera. Y'all, people would do nasty things in these rooms. Like, we actually had to like go in and be like, excuse me, she's been having seizures. Maybe now is not the right time for that, because they were trying to have intercourse on camera.
Jeez.
I was like, and also we don't want to watch that, so thank you very much. Because anytime she did any sort of activity, she had a seizure. So we really didn't want that anyway. I suppose it would, you know, show what you needed to see, brain activity. But I think there are other ways to do that. Okay. So it produces a brief disruption of electrical function of the brain, so like normal electrical function of the brain, and alters the ability of the brain to function. It affects your motor, sensory, autonomic, and she wrote psychic systems. I think she meant like psychosomatic. I don't know what she meant, but it does not affect your ability to tell the future. So you don't need to know that one. I don't know exactly what she was trying to say, but psychic is probably not it. It does affect someone's level of consciousness. So people, when they're having a stroke, are sometimes able to function a tiny bit, or right before the stroke, they can tell you that they're about to have a stroke. I mean, not a stroke, sorry, a seizure. Stop it, why'd you do that? Oh. Okay. Sorry, I didn't know my computer was falling asleep. Okay. Okay, hold on. I gotta get it back for you. Okay. But during seizures, people generally aren't fully conscious. They can't stay standing for the most part. There are some people who have like very small focal seizures, and they can still kind of sit or stand where they were, but they're not able to kind of function other than having that seizure. But for the most part, they're gonna end up on the ground. You're gonna have to like lower them down to the ground. It's something that happens a lot in hospitals where you have to think of like seizure precautions. Did you guys do that in health assessment yet? Putting like padded bed rails on and stuff like that, or putting pillows around them. Anyway, There's all sorts of precautions that you think about because they're not able to control their movements. They may or may not have convulsive movements, so you don't have to see someone shaking for them to be having a seizure. Sometimes they have, it's technically absence, but we call it absent seizures now, and it's like they look like they're just totally glossed over and they're not moving at all, but they're actually having a seizure. But the movements are known as tonic-clonic movements, which are a contract and relax type of movement. So they're caused by sudden changes known as paroxysmal depolarization in the membrane potential of neurons. The plasma membrane is thought to be more permeable, making them more sensitive. So people who have seizures, it's thought that the plasma membrane is more permeable. And then the seizure threshold may be lower in others and can trigger a seizure with various things. We see this in some children. So not all children have this, but some children have infantile febrile seizures, which are when they get a fever, they have a seizure. The only issue here is if their seizures last really long, because seizures tend to lead to a state of hypoxia in the brain. We don't want too little oxygen in the brain. So hyperthermia can cause seizures, hypoxia, hypoglycemia. It's something we worry about quite a bit with people who are diabetic, is that if they get too hypoglycemic, they can seize. Hyponatremia, because remember, salt has large effects on the brain. And what does potassium affect? The heart. Repeated sensory information, and then emotional, physical stress, fatigue, or lack of sleep. Nursing school friends. As we study for finals, make sure you're getting enough sleep. No? The answer is no? No, okay. All right, this one is on the exam. Infections altering neurofunction. Meningitis, which is an infection of the subarachnoid space. It is often bacterial. How many of you live on campus? Did you get your meningitis vaccines before you moved on campus? Yeah, did it leave a scar in your arm? I think it used to. I don't know if it does anymore. I swear, like every other year, you hear about a new meningitis outbreak at some college campus. And it can be deadly, which is not great. My dad is very Catholic. He likes the good Jesuits at Seattle U. And he went to UC Davis, though, for undergrad. And there was a meningitis outbreak, and so they all had to stop taking communion, which is like a sacrament in the Catholic Church, so it was bad. I don't know if it was considered a sin or not, but it's not a good day. Anyway, okay, so meningitis is often bacterial. Recovery depends on prompt treatment. So without prompt treatment, death is definitely possible. Sepsis is another possibility. Symptoms include headache, fever, stiff neck, and cerebral dysfunction. The main things we think about, like red flags, if your sister, your brother, your patient, whoever tells you they have a headache, a fever, and a stiff neck, that's like a red flag for meningitis. Okay, mostly headache and stiff neck. You think, well, is it just you slept wrong, or something going on? But when you add a fever, we think infection and we think meningitis. Encephalitis is it inflammation of the brain. It is often viral. It is difficult to diagnose. Treatment is supportive unless the etiology is herpes. Then acyclovir can be used. So if you know anyone who's ever had genital herpes, or you've had a patient who's had genital herpes, a lot of times they will take acyclovir to suppress the herpes. And that acyclovir can also be used for treating herpes on the brain, which sounds incredibly unfortunate. I need to keep my computer alive. Okay, brain abscess, so like a collection of pus in the brain. Okay, we've talked about this once before already in this class. They are mostly bacterial, almost always bacterial. They are necrotizing, meaning they can cause tissue death. And they are generally caused by infections from neighboring structures. So they happen a lot after people get dental work. They can end up with a brain abscess. But it can also spread from the sinuses, the ears, or penetrating wounds, especially penetrating wounds to large vessels. So you think like a stab wound or a gunshot wound that hits a large vessel, that bacteria can then travel and reach the brain. All right, delirium versus dementia. I have deleted a lot of the Alzheimer's slides and some of the dementia slides. I deleted all of the marijuana slides, sorry, but that is not on the exam. I don't know. For as many studies as there are saying you can use marijuana to prevent Alzheimer's, there are just as many studies saying that marijuana causes dementia. So I took them out, but I think Dr. Aparwa is a big proponent of medical marijuana use in Alzheimer's patients. Anyway, I'm not saying she does marijuana. Yes.
They did find a positive correlation between medical, like THC, CBD, whatever, and Parkinson's, though. It helps with the shakes.
Oh, I can imagine that. Yeah. Yeah. I don't know what to think. All I can say to you is that even though marijuana is legal in the state of Washington, it will show up on a drug test in a hospital, and you cannot have it in your system. So, if you're going to go work in clinical at a hospital that requires a urine drug screen, 30 days to clear it out of your system. All right. Anyway, let's move on. All right. Delirium versus dementia. So delirium has an abrupt onset. Delirium is more acute, okay? It's more of something that comes and goes, and it happens. What's one disease we saw previously that causes delirium in the elderly? UTI. It's a big one. Okay. Abrupt onset, it is typically physiologic in cause, meaning there's something going on in the body. Oh, don't do that. Okay, sorry. Physiologic going on in the body that is going to cause this delirium. It is typically reversible if it's treated. It has a fluctuating course and leads to altered levels of consciousness. You guys, I tried to jump out of my bed last night to use the bathroom in the middle of the night, and I didn't notice there was a shoe on the floor, and I rolled my ankle, and let me just tell you, my foot hurts. Okay, anyway. I'm just like sitting here, like hoping it goes away, and it's not. Anyway. Okay, dementia is a progressive failure of cerebral function. It is an irreversible confused state, and there is a decline in intellectual ability. If you've ever worked as a CNA in long-term care, you have probably worked with patients with dementia.
That will,
All right.
that will be on the exam, right? That slide?
Yes. Well, I'm not saying that it will be on the exam, but I'm saying you need to know it for the exam. Okay. Let's just be clear. Because some of them you need to know because they're right answers or wrong answers, right? Let's not totally take away your ability to study for the next week. All right, there are 3 consistent neuropathological hallmarks of Alzheimer's disease. This is definitely on the exam. You should just know it. Okay, amyloid-rich senile plaques. We have learned that amyloid is an infiltrate, and these amyloid-rich plaques are part of the cause of Alzheimer's disease, or at least are correlated with Alzheimer's disease. Neurofibrillary tangles or neurofibrillary tangles, where the neurons themselves get actually like tangled up. Ow, sorry, my butt hurts. And neuronal degeneration, so the nerves themselves start to degenerate. These changes eventually lead to clinical symptoms, but they begin years before the onset. So Alzheimer's, a lot of people won't know they have it until they start having symptoms, even though the damage has progressed to a certain point by then. Alzheimer's disease begins slowly, for the most part. That is not always the case, but for the most part, it begins slowly. At first, the only symptom may be mild forgetfulness, which can be confused with age-related memory change. So most people with mild forgetfulness do not have Alzheimer's disease, okay? All of us, because as our brains get older, that's just how things work. We will start to have a little bit of memory trouble, like word finding. I feel like I'm 36 and I already have trouble with word finding. In the early stages, people may have trouble remembering recent events, activities, or the names of familiar people or things. They may not be able to solve simple math problems, it's issues that may be bothersome, but usually they are not serious enough to cause alarm. My foot has just like really decided to hurt, so that's we're just working through this at this point. Okay. In the middle and late stages of Alzheimer's disease, symptoms are more easily noticed and become serious enough to seek medical help. Forgetfulness begins to interfere with daily activities. People may forget how to do simple tasks, such as brush their teeth and comb their hair. Once people are unable to take care of themselves and do their own activities of daily living, they become reliant on others, right? So they're going to need like home nursing and things like that. People begin to fail to recognize familiar people and places, and they may have problems speaking, understanding, reading, and writing. And then in the late stages of Alzheimer's disease, people become anxious or aggressive and may wander away from home and eventually need total care. And a lot of that has to do with their safety, because as people wander away from home, there's just a lot that can happen. You guys have probably seen the silver alerts on the freeways if you drive. There are people who, for the most part, have wandered away from home. All right, Parkinson's disease. It is a motor system disorder. It is due to the loss of dopamine-producing brain cells. You should know that. Definitely know that. The 4 primary symptoms of Parkinson's disease are tremor, including trembling in the hands, arms, legs, jaw, and face. People with Parkinson's also do something called pill rolling. So some people with early Parkinson's who don't have a really pronounced tremor, they might roll their fingers like this, and it's called pill rolling. Rigidity, including stiffness of the limbs and trunk. Bradykinesia, so think about that. Brady means slow, and kinesia meaning movement, so a slowness of movement. And postural instability, including impaired balance and coordination. They also tend to have a shuffled gait. So they're not able to like pick their feet up off the ground, so they shuffle their feet along the ground. It's called a shuffled gait. As symptoms worsen, patients may have difficulty walking, talking, or completing other simple tasks. I think I deleted some slides here. Yeah, okay. I was just going to say, my uncle has Parkinson's disease, and he, it was like treatment resistant. It was like resistant to medications, which is on one of the slides I deleted, was medications. So he has a deep brain stimulator, which is also on one of the slides I deleted, but we don't talk about treatments on the test, so I just left it. But it's cool. It's like a pacemaker for his brain, and it sends out like electrical impulses in his brain. It's interesting. Parkinson's disease usually affects people over the age of 50. Early symptoms are subtle and occur gradually, but in some people the disease progresses more quickly than in others, which is, I feel like, the same with all diseases. Other symptoms of people with Parkinson's disease include depression or emotional changes, difficulty swallowing, chewing, and speaking, and that often has to do with the tremor. It makes it more difficult to have a coordinated swallow or coordinated movements in order to speak. Urinary problems or constipation, skin problems, which we looked up in the other class, are mostly just skin problems associated with people who have Parkinson's disease, not necessarily caused by Parkinson's disease, although some of the medications can lead to skin issues. And sleep disruptions. There are no blood or laboratory tests available to diagnose Parkinson's disease.
Do we need to know this slide?
The other symptoms wouldn't be unhelpful. I'll just say that. And maybe for like a wrong answer. I don't know. I would know that Parkinson's and dopamine, they're buddies, okay? That's what I would know. All right. Is that it? Is that the last one? Oh, no, I'm on the wrong keyboard. All right, multiple sclerosis. Multiple sclerosis is a problem with the myelin sheath on neurons, on the axon. So it's a degeneration of previously normal myelin with relative preservation of the axon itself. Myelin affects the speed at which impulses travel down the axon. So they're going to travel much more slowly without a myelin sheath. Okay?
Really focuses it, right?
What?
With a myelin sheath kind of keeps it contained.
It keeps it contained, but it also helps it move quickly. Like it helps the impulse get from one end of the axon to the other onto its target very quickly. Yes?
The way my anatomy and physiology professor explained it was it's essentially like a power cord almost, where all of the wire that's transmitting the electricity is inside, and then it's wrapped in the rubber to
Yeah.
send it through.
It is kind of, yeah, that's kind of how it works. Although, it's hard because the rubber on a wire is meant to protect us.
Yeah.
Anyway. It may occur when there's a previous viral insult to the nervous system in a genetically susceptible individual. So people with multiple sclerosis are generally genetically susceptible. They have a family member who has had multiple sclerosis, or they know that they have a family member who had some sort of neurodegenerative disorder. But in all, they have some sort of genetic susceptibility. And then if they get a virus, it can affect the nerves in a way that it leads to the multiple sclerosis becoming active. It is an autoimmune process, so CD4 T cells cross the blood-brain barrier, followed by chemotaxis and infiltration of monocytes and macrophages. And then T cells become autoreactive to a single myelin protein and destroy the myelin protein on the neurons. No, we are so close. Maybe that's the end. Hold on. That is the end. No, I lied. There's one more. Okay, hold on. It's coming this way. Okay. Okay, I gotta figure out how to fix this. All right. Stress seems to trigger the onset of symptoms or worsen symptoms of multiple sclerosis. Symptoms include paresthesias, which is numbness or tingling. A lot of people feel paresthesias in their fingers. It's that feeling you get when like a limb falls asleep. That's paresthesias. Weakness, a strange sensation of tightness, banding, itching, or constriction. Imbalance and ataxia, which is a lack of coordination. And visual changes, including blurring and double vision. The onset is between the ages of 20 to 40, and the male to female ratio is 1 to 2, meaning twice as many females get multiple sclerosis as males.
Is there a known reason for that?
I don't know. Maybe genetic inheritance, but I don't know the answer. Okay, there is a third neuro slideshow. All right. Yeah, it's not very long. But we can get through it before the end of class. That way, all we have left is reproductive.
So are we going to do the Kahoot at the beginning of next class? Is there a Kahoot?
Well, the Kahoot's already posted. You mean like a new Kahoot?
Oh, sorry. I wasn't paying attention at the beginning when you were talking about it. I thought you were saying you were done.
No. So, we'll see what we get to. Okay? We'll see what we get to. I feel like telling you the exact slides to study is hopefully somewhat helpful. Okay, let me just find this last one. Reproductive is also very short. Okay. Is there? There it is. Okay. Neuro 3. Here we go. We're not going to watch this video because everything you need is in the slides. Myasthenia gravis. So I was told in nursing school that myasthenia gravis was like all over the NCLEX. And I don't think I had a single myasthenia gravis question on the NCLEX. But apparently, it's everywhere. I don't know. It is a chronic autoimmune disorder. The immune system produces antibodies that attack the neuromuscular junction and the postsynaptic membrane. We talked about this when we talked about bilateral fatigable weakness, right? If we have bilateral fatigable weakness, it's most likely occurring at the neuromuscular junction, and that is associated with myasthenia gravis, okay? These antibodies attack acetylcholine receptor sites, and they are destroyed. This results in weakness and fatigue of skeletal muscle. It mostly involves the bulbar muscles of the head and neck that control swallowing, speaking, and chewing. If it starts to affect respiratory muscles, it can become life-threatening. Signs and symptoms include weakness in the extremities, drooping eyelids, difficulty swallowing and chewing, shortness of breath, slurred speech, and difficulty making facial expressions. There is no cure, but immunosuppressive therapies can help, just like any other autoimmune disease. Headaches. Yay. Okay, are any of you guys planning to go to NP school at some point in your lives? A few of you, maybe? Okay. Headaches are a very common concern in the nurse practitioner world. Headaches can be primary or secondary. So primary causes include migraine, tension headaches, cluster headaches, and others. And then secondary causes include tumors, meningitis, elevated intracranial pressure, often abbreviated as ICP, head and neck conditions, including eye, ear, sinus, and dental etiologies, hypertension, infection, and vascular causes such as dissection and aneurysm. Red flag symptoms of headaches. So a lot of headaches are very benign, treatable but benign. But there are some red flag symptoms. So one of the biggest is an abrupt, what's known as a thunderclap onset. It's very sudden and it's extremely powerful. It's like all of a sudden you felt like your head was, I don't know, being stabbed by a million knives, or you all of a sudden had a huge amount of pressure in your head. Like it's a very big, fast onset. And the most likely cause of this is a hemorrhage, so a vascular cause. You are bleeding. An aneurysm, a brain aneurysm, is one of the big causes. I've heard of people getting these on airplanes. They get increased pressure in their head, and it like ruptures an aneurysm in their brain when they're flying.
My uncle died like that.
Oh,
He was on the plane. No, it was this year. He was,
wow.
or last year. He was on the plane, and then once they got up at like an altitude, he died.
Yeah,
Like,
it's that
something,
increased
like,
pressure.
happened and he died.
Oh, it's so scary and sad. If you have a headache that is worse at night or with coughing, sneezing, or the Valsalva maneuver, we're concerned for increased intracranial pressure. Remember, the brain is an enclosed space. Are we up? Yeah, okay. If you have a headache that is co-occurring with a fever, we're worried about infection. So we'd be worried about things like meningitis or even like a brain abscess. And then if someone has a history of cancer and they have a new persistent headache, we worry about a metastasis. We worry about the cancer spreading to their brain. The most common primary headache disorders, so migraine. Migraine is typically unilateral. It occurs on one side of the head. They'll say my right side of my head or my left side of my head feels horrible. It can involve photosensitivity, which is sensitivity to light, severe pain, nausea, and vomiting. It can be accompanied by a visual aura, and it can last anywhere from a few hours to a few days. Causes include genetics, so a lot of people, their mom, their dad, whoever also had migraines. Hormonal changes, lack of sleep, weather changes, or other factors. A lot of people get migraines around menstruation or around menopause or pregnancy. Tension headaches are dull, moderate pain lasting anywhere from 30 minutes to a few days. These are extremely common. It tends to be caused by the muscles around our head and face. Cluster headaches, these I've heard are absolutely awful. Unilateral severe periorbital pain that occurs in clusters. So it's pain around the eyes, around one or both. It can last anywhere from 15 minutes to 3 hours, but tends to peak at 10 to 15 minutes. It can be chronic or episodic, and they tend to occur in cluster periods. So you have a bunch of these over the course of days, weeks, or months, and then you have periods of remission. And your remission can also be days, weeks, or months. Although it does tend to be on the longer side. So you'd suffer for 3 days, maybe you get a remission for a few weeks or something like that. Symptoms include red watery eyes, stuffy nose, photosensitivity, and forehead sweating. It is possibly related to a sudden release of histamine or serotonin in the body. Oh my gosh, that's it. Okay. I'll figure out how to work my phone.